Hi, Raphael here, and here is Ask Me Anything for the 10th of July 2020. Marion asks, can I ask what is your recommendation for people who are finishing the course in a few weeks? How can we advertise and find new clients? Do we still need insurance to teach people, or is it still covered with our students' insurance? And Megan also wants to know the answer to that. Well, Marion, there are a couple of questions there. One is about insurance and one is about how do you find new clients. So the insurance one is very, very straightforward. Whilst you're a student and if you are teaching unpaid sessions, so in other words, you are not paid for the session, you're covered by our insurance. So if you're teaching your classmates online, or if you're teaching friends and family, if you're teaching at a studio, and even if the clients at the studio paid, if you're teaching, like say you take the warm-up in a class or something, but you're not paid for the session, then you're covered by our insurance because you're deemed to be teaching as in a student capacity. So if you, as soon as you graduate though, you're not covered by our insurance because you're not a student anymore. So as soon as you graduate, you'll need to get your own insurance, and that's very, very easy to do. We've got a relationship with a company which you'll find in e-learning, which will get you a bit of a discount. In Module 5 of your e-learning, there's a video explaining how to get insurance. It's very, very simple. Now, as to advertising and how do you get clients, well, if you're thinking of teaching online, I think what a great time and what a fantastic opportunity, because your clients are now not just limited to people who live nearby. Your clients could be anywhere in the country or anywhere in the world. So I would say your first place to advertise is your social media feed. So even if you've only got a couple of hundred followers, just put it up, put it out there. Say, hey, I'm doing, Matt Pilates class online at this time and this time. Love to have you there. DM me for, to book. And, mention the price as well. Now, think about the timing of your classes in relation to time zones. So, think about where are your followers? Like if you're on Instagram or Facebook, physically, and where in the world are they? Because, for instance, if you're on the east coast of Australia, Melbourne, Sydney, Brisbane, you're 2 hours ahead of Perth. So if you run a midday class in Melbourne or Sydney, it'll be 10 a.m. in Perth, it'll be 2 p.m. in Auckland. Whereas if you run an 8 a.m. class in Melbourne or Sydney, it'll be 6 a.m. in Perth, which might be too early for people. Whereas if you run a 6 p.m. class in Perth, it'll be 8 p.m. in Melbourne, that might be too late. So if you run kind of classes in that mid part of the day, from kind of mid-morning, Melbourne time to, mid-afternoon Perth time, you should be able to get a whole spread of time zones in there, and possibly even the west coast of the US. Like if you're in San Francisco or LA or Portland or San Diego, all of those west coast cities, they're only 6 hours behind us. 6 hours ahead of us. So, midday in Melbourne is 6 p.m. in LA or 5 p.m. in LA, depending on daylight saving. So if you kind of, look at where your followers on social media are, where in the world, they are, and just timetable classes accordingly, thinking about their work days and whatever, and then just put it out. And don't be afraid to DM people, direct message people on social media and just say, hey, here are my classes, they're this time, it's, here are the benefits for you, and here's the price, and here's how to book in. And I can't tell you how strongly I recommend charge full price. Don't undersell yourself. It's not it doesn't make you more attractive if it's cheap or free. If you offer me something and it's way cheaper than I expect it to be, my first thought is, what's the catch, or is it broken, or is it really poor quality? So you'll probably get more clients at a a fair price than you will at a super discount price. And you'll also feel better about yourself if you charge the right amount. So I would recommend charging full price, like, $15, maybe $20 for an online mat work class. And you can limit the class to, 10, 15, 20 people, whatever number you want to limit it to, or you can make it unlimited. It's up to you. All right. Hope that helps. Shari asks, good morning, Raf. I would love to see an AMA brief on the topic of neutral versus imprinted positions. The why of the current recommendation towards pressing our waistband to the mat rather than working to maintain neutral as strength permits. So just for those of you who don't know Shari and haven't heard of neutral versus this thing called imprint, if you were trained in something called Stott Pilates, which is a Canadian Pilates organisation brand, they have this thing called imprint, which is a very, very slight posterior pelvic tilt. So in other words, when you're lying on your back, you press your low back very slightly towards the mat, not jam it into the mat like Joseph would have you do it. And that this is kind of a thought, it's presented in Stott Pilates as this is the kind of beginner-friendly position that people can use until they develop strength to be in neutral, which is to kind of have the kind of normal arch of your low back, off the mat when you're lying supine on your back. And so this comes out of the genesis, the history of Stott Pilates, as well as other styles of contemporary Pilates, which were all kind of, roughly sort of emerging in the mid-90s. And that's when Moira Stott, who was the progenitor of Stott Pilates, was first teaching her classes and courses and starting to document her system, towards the late 90s. And, she was one of that second generation of teachers, the people who were taught by the people who were taught by Joseph. And they all kind of emerged roughly around that same time, so Brent Anderson in Polestar Pilates, Ray Liskowitz with Bazzi Pilates, there were a few other that kind of all emerged around about the same time and collectively are called, contemporary Pilates. And at that time, whilst Moira Stott, now Moira Merrithew, was making up her system, not making up, but consolidating and documenting her system, the current science at the time was emerging through biomechanics and physical therapy and exercise science was that neutral spine, keeping your spine relatively straight, was thought to be safer and protective. So Moira and others in different schools of Pilates incorporated this into the style of Pilates, and in fact, Pilates at that time was very heavily influenced not just by physical therapy and biomechanics, not just with the idea of neutral spine, but the whole idea of isolating muscles. Was never part of Pilates originally, and it came into Pilates in that contemporary Pilates era, influenced through physical therapy, which physical therapists was American physiotherapists, that's what they call them, was starting to get into Pilates at that time, and they brought in these ideas of isolating muscles, activating the pelvic floor and the transversus abdominis, the deep muscles of the lumbopelvic region. So all of these ideas came from physical therapy and exercise science, and since then. The science has continued to move on, and it's not that was wrong per se. It's just that science, the very nature of science is it incrementally improves over time. It iterates, and we find a way of doing it that works a certain amount, and then over time we find a way that works slightly better and slightly better and slightly better. And, sometimes it takes great leaps forward, but generally it's, tiny little steps. And so, 20 years later, the science has, moved on quite considerably. And we now know that isolating individual muscles as well as neutral spine itself are not especially protective. And, that the imprint position, or the very slightly flexed position of the low back, is not easier or harder per se. It's just a different position. So I think the current science pretty strongly shows that neither position is better or worse. And so it's not that, when we advocate the imprinted position, in fact, we don't advocate imprint, we advocate what Joseph said, which is press the spine firmly towards the mat or floor, which is much more than an imprint. It's a firm pressure towards the mat or floor. We advocate it not because of any biomechanical reason, but simply because that's the way Joseph intended it to be done. And he quite explicitly states in his book, Return to Life Through Contrology, that, when in the supine exercises, always press the low back firmly towards the mat or floor. So that's the way we teach it. Now, what was his rationale for that? I can only guess. He didn't say. But there are two things. One is he, had this idea of the spine should be perfectly straight in posture, which has since been shown not to be accurate. And secondly, my guess is that he knew that it activates the lower abdominals more effectively. So when you're in this position where you kind of flatten your low back and at the same time lift your chest, it maximally shortens these anterior inferior fibers of a muscle called external oblique, essentially your low abs down here. And so that is the position that, in fact, maximally recruits the lower abdominals. So when you're lying on your back, if you lie flat on your back and press your low back firmly to the mat or floor with your legs straight up in the air, and then keeping your low back pressed firmly to the mat, you gradually lower your legs, what you'll find is it really works your low abs very hard. So I hope that helps, Shari. I'm sorry, I don't have either a much more concise or a much more detailed explanation for you. I do have a much more detailed explanation, but it literally takes 90 minutes to walk through all of the biomechanics of the spine in neutral versus flexion. And if you are interested and haven't already seen it, do the Anatomy 1.0 course, because that has, or is it Anatomy 2.0? Anyway, look at the anatomy course pages and look for the content, because one of the episodes of one of those courses specifically is a deep dive into the anatomy and biomechanics of what happens inside your low back in neutral and in flexion. And it is a full discussion for 90 minutes on just that topic. So I hope that helps. Okay, Sarah asks, hi Raf, not sure if this was covered in the new Cert 4, but we didn't touch on it much in the old one. It came to my attention recently because a client asked me, should we, or is it important to cue breath, i.e. exhale, inhale, lower, lift, whatever it might be. I've never been one to cue breath, but a client asked me the other day, is it inhale or exhale to lower? And I replied, whatever feels good. And she looked at me like I was an idiot. It got me thinking about how important breath patterns are in Pilates. Well, Sarah, I'm going to say there are some reasons to cue breath and some reasons or situations not to cue breath. So it's not an either or. When it can be useful to cue breath would be to relax, to calm and focus. So perhaps at the start of class when people come in and they're a bit frazzled from their day and you want to sort of bring them into the present moment, so they're present for the class, focusing on breath can be a great way to do that. Maybe at the end of class when you want them to relax, or in transitional moments in between exercises when they're into a shell stretch or during their mermaids or something. So these times focusing on breath can be really nice because it can enhance their experience and their pleasure in the movement. When you're in shell stretch, it feels nice to focus on your breath. When you're in mermaid, it can feel really nice to focus on your breath. So that's something. Sometimes it can help people find a shape. So I'm sure you know from your own experience that naturally when you inhale, you extend your spine, and naturally as you exhale, you flex your spine. And that's the case not just for big inhalations and exhalations, but even if you just sit quietly, sit up relatively straight, not ramrod straight, but just sit relatively straight and just breathe quietly. And you'll notice that as you inhale, there is a very slight extension of the spine. As you exhale, there's a very slight flexion of the spine. And that is just a normal part of the mechanical process of breathing. So if you're bending forwards, exhaling can enhance that shape. So in something like maybe a spine stretch, exhaling and squeezing the air out of your lungs can help find a deeper stretch. And likewise, in something like a swan dive or, breaststroke on the reformer, something like that, inhaling can help you find more extension. So that might be a time to, use breath, and also to prevent breath holding. Now, as a general rule, I think breath holding is perfectly fine and I don't have a problem with it because people always breathe eventually. But for certain people, so for pregnant women and also for people with high blood pressure, breath holding is not a good plan because when you hold your breath, it increases your blood pressure. So for pregnant women and people with high blood pressure or hypertension, as it's called, it's a good plan to cue them to breathe through the movement. Now, it doesn't matter if they breathe in or out, but just breathe, don't hold your breath. And if you wanted to, you could cue them breathe out with flexion and breathe in with extension. Now, when might it not be helpful to cue breath? Well, I would say for beginners. They've got so much novel stimulus, new environment, new physical sensations, new people, new instructions about a movement, and they probably don't need additional data points coming in about when they should be breathing. When you're doing a complex or high load exercise, if you're asking someone to do something that's essentially really hard, like telling them how to breathe while they're doing it is just going to distract them and detract from their ability to learn and perfect that movement. And thirdly, like when they're already breathing just fine, that's when I don't think it's helpful to cue breath, because breath doesn't inherently add anything to the exercise, except in some specific situations, many of which I already have touched on, and there are probably a couple of others. But, if it ain't broke, don't fix it. I think why would you cue breath is a really useful question. So there you go. I hope that helps, Sarah. Kim asks, "Hey, Raf, really appreciating the AMA chats. Quick question for you. My friend just gave birth over a month ago and is experiencing shooting pains in her thumb and wrist. Having a little Google on it, I think it might be de Quervain's tenosynovitis. I've read that rice and a wrist splint can help. Rice is rest, ice, compression, and elevation. And general stretching and strengthening. Is there any particular Pilates moves you could recommend, or should a generalized exercise program suffice? Thanks." Kim, I can't help you on the diagnosis because I haven't seen the person and I can't diagnose. So, but if, based on what you've said, she had a baby a month ago and now she's got a pain in her thumb and wrist, it sounds to me like it might be a too much too soon type scenario. Like she's gone from never holding a baby a month ago, to 29 days ago, all of a sudden she's holding a baby 15 hours a day, potentially in super awkward positions with the baby asleep and doesn't want to wake it. And she's just potentially just overloaded the tendon in that thumb. And tenosynovitis, if that is the diagnosis, is the synovium is the wrapping, the sheath that goes around the tendon. And all tendons have a synovium. And synovium, we also have a synovium around our joints. It's just a sheath of connective tissue or fascia that goes around the joint, and in this case goes around the tendon. And that's because as the muscles move, the tendon, glides past the other tissues next to it, and we don't want the to prevent the tendon rubbing on those tissues and irritating the tissues, it has a little sheath around it. Just like if you've ever ridden a push bike that has hand brakes, the brake cable goes through a tube, so it doesn't rub on the other parts of the bike. And the tube in tenosynovitis, the sheath, has become inflamed because itis means inflammation. So tenosynovitis just means inflammation of the sheath around the tendon, if that's what the diagnosis is, which it may not be, but if it is. And inflammation is just a sign that something is irritated, through too much increase in activity in a short space of time, or too much load in a short space of time. And the way to deal with too much load in a short space of time is to reduce the load to a manageable level and then gradually build the load back up again. And so the way you could reduce the load would be, hold the baby a different way. So maybe instead of holding it with your hand, hold it with the elbow. Maybe get a cushion to go under the hand so you're not using your strength to hold it up. Get a different chair with an armrest in it. There might be get a baby Bjorn sling or something. So there might be some kind of biomechanical intervention or sort of ergonomic intervention that you could help her with that would involve reducing the load on that body part. And that may well be enough to solve the problem. Now, if it is de Quervain's tenosynovitis, which would need to be confirmed by a medical professional, probably by ultrasound diagnosis, then corticosteroid injections combined with a splint may also help. But if it was me, I would try modifying biomechanics first and see if that helps. Okay, Meech asks, "Hi Raf, I liked the lesson on Saturday. Can a snapped Achilles tendon repair itself without surgery?" And the answer to that is yes, it can. I did a Google Scholar search and found a systematic review. I think it was a systematic review. Let me just check. That looked at ankles. Multi-center randomized trial using accelerated functional rehabilitation. So this is from 2010, operative versus non-operative treatment of acute Achilles tendon ruptures. Patients were randomized, a total of 144 patients, 72 treated operatively and 72 treated non-operatively. Were randomized, there were 118 males, blah, 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 blah. Conclusions, this study supports accelerated functional rehabilitation and non-operative treatment for acute Achilles tendon ruptures. All measured outcomes of non-operative treatment were acceptable and were clinically similar to those for operative treatment. In addition, this study suggests that the application of an accelerated rehabilitation non-operative protocol avoids serious complications related to surgical management. So there you go. Apparently, without surgery, Achilles tendons can heal themselves. Does that mean that you shouldn't get surgery? Not necessarily. This is only one study, and also the outcomes weren't identical between the groups. They were similar. So I think the surgery group did have slightly better outcomes, but clinically not much noticeable difference for the patients. So I think it's still a decision to be made on a case-by-case basis. Caitlin asks, Raf, thanks so much for the AMA. It is such a great thing to have. I wanted to know if you had any info on specific exercises to assist with ab separation after being pregnant. Well, Caitlin, the answer to that is yes. Ab separation happens to 100% of women. It's not just normal, it's universal by full term of gestation. Now, for about 2/3 of women, so 67%, it goes away all by itself within a year after giving birth. So, but for a third of women, it doesn't go away by itself. And if it doesn't go away within a year, it tends to not go away. Now, exercise has been shown to reduce the size of the separation and also to help it go away more quickly, but exercise has never been shown to eliminate the separation. So I would say if you're less than a year postpartum, you're probably going to find it's going to go away all by itself. And abdominal strengthening of any kind has been shown to improve that, even further. And if you're more than a year postpartum and you still have a separation, I would say there's a really good chance it's not going away. And exercise, while it probably will slightly reduce the size of the separation, it very likely won't get rid of it. And that if, getting rid of it completely is very high priority, then, surgery is probably the only option if you're more than a year postpartum. Having said that, there's no particular reason to get rid of it aside from cosmetic, which is a valid reason, but, it's not related to increased rates of back pain, pelvic organ prolapse, pelvic muscle dysfunction, urinary incontinence, anything like that. It's the consideration is purely a cosmetic one. So I hope that helps. The particular types of abdominal strengthening that have been used in these studies are quite varied. So they've tried everything from planks to curl-ups to leg lowers to side planks to twists or, core activation, all kinds of different things, and it all seems to work. So basically, I would recommend any and every type of abdominal strengthening. I hope that helps. Julie asks, "Hi Raf, I'll limit myself to one question a week for AMA. Ha ha ha. This is my question this week. In relation to pregnancy versus strength training, how does this vary in terms of load? Obviously, I'm thinking isometric holds and body position is the same as Pilates protocols. But when it comes to strength training, how safe is it for a person who is pregnant to be lifting heavy loads like deadlifts, squats and bench? Would have me feeling rather concerned about incorporating these into a program for someone in late and even early stages." Well, Julie, I did some research and here's what I came up with. This article, and I can't recall the publication date, but it's sometime in the last 10 years or so. The effects of vigorous intensity exercise in the third trimester of pregnancy, a systematic review and meta-analysis. Results, 10 cohort studies of 32,000 women and 5 randomized controlled trials of 623 women were included in the systematic review, with 13 studies included in the meta-analysis. No significant differences existed in birth weight for infants of mothers who engaged in vigorous physical activity and those who lacked this exposure. Moreover, no significant increase existed in risk for small for gestational age, low birth weight, or maternal weight gain. Women who engaged in vigorous physical activity had a small but significant increase in the length of gestational age before delivery. Mean difference 0.21 weeks, or in other words, about 3 days or something like that, and a small but significantly reduced risk of prematurity. Conclusions: findings from this meta-analysis indicate that vigorous intensity exercise completed into the third trimester appears to be safe for most healthy pregnancies. Further research is needed on the effects of vigorous intensity exercise in the first and second trimester, and of exercise intensity exceeding 90% of maximum heart rate. So it appears that vigorous intensity exercise is perfectly safe if you want to go to CrossFit, as long as you're already fit. Go for it. I would, just for the sake of caution, not exceed 90% of your maximum heart rate, which is really, really hard intensity exercise. Like running up a hill with a sand dune with a rubber tire tied around your waist, you probably would get close to 90% of your maximum heart rate. But yeah, basically, if you want to deadlift, bench press or whatever, go for it. But just don't do the Valsalva maneuver. Okay, Gabrielle asks, this was fantastic, AMA. Thank you. Can I ask about Pilates considerations for someone with Scheuermann's disease of the spine? Are they similar to the osteoporosis considerations you shared? Cheers, Gabrielle. Well, Scheuermann's disease, and I'll see if I can successfully spell it. Also called Scheuermann's kyphosis, is a condition which is an idiopathic condition, which means we don't know what causes it. but possibly genetic, which is onset in adolescence, where the vertebrae of the thoracic spine, so that's the part of your spine where your ribs are, grow kind of wedge-shaped. So in other words, they're shorter at the front than they are at the back. So they have this kind of wedge shape. And what that means, what that causes is basically when you add, a whole bunch of those on top of each other, the spine assumes this quite rounded position, or this rounded position is also called a kyphosis. And so that rounded position of the spine, or Scheuermann's disease, Scheuermann's kyphosis, is the typical sign of Scheuermann's disease, although it needs to be confirmed by X-ray or whatever with a doctor. And it's typically a self-limiting condition, so it onsets in adolescence, but it doesn't just keep getting worse and worse and worse and worse and worse. It onsets, and then it kind of, as the vertebrae grow into that shape, so the front of the vertebra doesn't grow as quickly as the back of the vertebra. It ends up wedge-shaped, but then it kind of just, it stays there. It doesn't just keep getting more wedge-shaped. So people with Scheuermann's disease, I did a Google Scholar search on this, tend to have somewhat more back pain than people without, and it tends to be slightly more intense. But they don't seem to have any other real issues. So people with Scheuermann's disease don't have lower bone mineral density, don't have higher fracture risk than people without Scheuermann's disease. People with Scheuermann's disease don't typically have reduced lung function. So often people who are very, very kyphosed have reduced lung function simply because their lungs can't expand. But people with Scheuermann's disease whose curvature is less than 100 degrees, which is very extreme, have normal or even above average lung function. So basically, and they don't seem to have poorer mental health, poorer body image, poorer self-esteem, any of that. Basically, they're just normal people. They just happen to have a somewhat curved spine. In terms of biomechanics, they don't extend. Just because of the actual structural shape of the spine, their thoracic spine, the part with their rib cage, tends to be essentially locked, and so they're very stiff in extension, and that's not something you can fix with stretching or exercise. It's just the structure of their body. So whilst you can give them spinal mobility exercises for their low back and for their neck, and that's probably going to be a great thing, there's not really anything you can do about the Scheuermann's disease. It's not something you fix. You just give them regular old exercise like anyone. They're perfectly safe to do everything. The only thing you'll find is they're not very bendable in their thoracic spine, particularly back bending. So, things like, because they're very rounded, they might find lying on their back very uncomfortable because their head's going to go like that. So you might want to give them some kind of head prop, like a little pillow or cushion or something to put under their head just so they're comfortable. And lying on their tummy, because they're very kyphosed, it's going to be really hard for them to get, their arms off the floor in that position. So you might want to give them something to lie on, like maybe a reformer box or something on the floor, or an ottoman or a cushion under there, bolster under there, so that they can get their arms up, off the floor to do things like swimming. But aside from that, it's really just a biomechanical consideration just in terms of their range of motion. That's the really only thing. And it's just about comfort and their ability to do exercises. You're not going to be able to stretch them out of it, and you're not going to hurt them. So, yeah, hope that helps. Janice asks, Horaf, are there any exercises no-go for low PAPP-A during pregnancy? Now, I did look up what low PAPP-A is, and I forgot what the acronym stands for, so I'm just going to see if I can refresh my memory very quickly. Here with Google. PAPP-A, pregnancy-associated plasma protein. That's what it's called. All right. Pregnancy-associated plasma protein. And plasma is just your blood. And it's a protein that is released very early in pregnancy and throughout pregnancy by both the mother and the fetus. And low PAPP-A, it's one of the things that is routinely kind of measured during pregnancy. Low PAPP-A is associated with a whole host of things, including low birth weight, premature labour, pregnancy-induced hypertension or high blood pressure, which in pregnancy is a very serious medical condition, and intrauterine growth restrictions, so where the baby is smaller than expected for its gestational age, and that's throughout the pregnancy. So essentially, these women with low PAPP-A are a high-risk pregnancy, and they shouldn't be exercising in a group exercise class. So they should either be not exercising, or they should exercise only under supervision of a medical professional. So are there any exercises no-go for low PAPP-A during pregnancy? I would say all of them are no-go. Unless under direct supervision, like physically in the presence of a medical professional. Hope that helps, Janice, and I'm glad you asked. Suda asks, thank you, Raphael. How do you release prolonged hamstring tightness? Despite doing stretches, yoga, foam rolls, there is a tension that is stubborn to release. So I would distinguish here, Suda, from what I think you mean is the subjective experience of tension and tightness in your hamstring. So you have a body sensation of tension, which is not the same thing as restricted range of motion. So I have very tight hamstrings, like I can't touch my toes comfortably, but I don't have any subjective feeling of tightness. You know, my hamstrings are perfectly comfortable unless I try and touch my toes. So if I've understood you correctly, you're experiencing subjective, body sensations of tightness in your muscles, and foam rolling, stretching, and yoga hasn't helped. So my suggestion there would be strengthen through range of motion. How would you strengthen through range of motion? Well, load your hamstrings in a forward bend position, essentially. So you could do standing forward folds with little dumbbells, or some other little hand weight. I'm thinking like a couple of kilos in each hand sort of thing, not a heavy weight. Or do a seated forward fold with a little weight, like a 5 kilo weight plate or something on your back. And I would do that either, you could do holds, but I would be more tempted to just move through range with those exercises, and just to do a little bit, just to do like 30 seconds, 5 to 7 days a week. Not, when I say loaded stretching, I don't mean Romanian gymnastics national team level super intense loaded stretching. I just mean a few gentle forward folds with a light hand weight, in your hands, or a weighted bar or something like that, a broomstick with a weight plate on the middle of it. Just go to YouTube and type in, weighted stretching, loaded stretching for hamstrings, and there'll be heaps of people there. Jefferson curls are another one that you could look at. But, I would just start doing a little bit every day, and think of it as a strengthening exercise rather than a stretching exercise. So rather than trying to go further and further and further, try and increase the weight over time, gradually. I hope that helps. Shruti asks, hey, Raphael, I've been enjoying the lectures and videos on e-learning so much. Well, thank you, Shruti. My question, when you give exercises to a client with an injured arm or leg on one side in a rehab session, do we balance and work equally on both legs or arms, or only work on the weaker side, or sometimes more on the weaker side? I've heard various opinions on this and wanted to know your take. Sorry for the long essay. So thanks, Shruti. Hey, Shruti. Well, it depends on the client's goals. So, and how much time you have with them. So if you're working with a client and they're recovering from a knee injury, say, or knee surgery, they'll have very reduced strength and range of motion on the injured side. And so your goal will be to bring that up to equal their uninjured side. And that's kind of a generic goal of rehab, whether it's a shoulder or knee or hip or whatever. It's, so that the injured side is as strong and as flexible as the uninjured side. That's often the end point of rehabilitation. Now, if the goal is not so much about symmetry as it is about it's assuming that the uninjured side is strong enough to cope with the demands of whatever they throw at it in life because it didn't get injured, right? So if it was not injured, that suggests that it had enough load tolerance to cope with whatever load was thrown at it. So it's not so much about making them symmetrical as it is about taking the uninjured side as a benchmark and then going, okay, well, that's how strong this person needs to be on both sides. So if you have an injured knee or you have surgery on your knee and all of a sudden you can't do squats, you can't run, you can't, walk upstairs, you can't, do the cross trainer at the gym, you can't do feet in straps, you can't do footwork in Pilates, like all of these things that strengthen your legs, you can't do it. So what happens to your uninjured leg? It gets weaker. So if you just work the injured leg, well, you'll increase the strength in that quite quickly, and pretty soon it'll be the same as the uninjured leg, but the uninjured leg is going to get weaker at the same time as the injured leg gets stronger, and they'll meet in the middle somewhere. Now they'll both be equal, but they'll both be weaker than the uninjured leg originally was. So they, in theory, won't have the load capacity that person needs to withstand their activities. So I would absolutely implement some strategy for maintaining strength in the uninjured legs and arms. Now, that may or may not happen in your Pilates session. Like they might go to the gym and work their other leg in a one-legged leg press or something, or they may have someone else that they work with to do that, and they're only coming to you to work on their injured leg. And so it might be perfectly, ideal, in fact, for you to just work on the injured leg, because that way you progress that really quickly and they've got someone else working with them on the rest, or they can do the rest by themselves. Or they might not have someone else and they might not have the confidence to do a workout at the gym or at home on their other body parts without, compromising their injured leg. So it might be best for you to take them through a workout that challenges their uninjured body parts at least enough to maintain their strength, the existing level of strength that they had, so that you're truly bringing their injured body part back up to the level it needs to be at, not to some kind of lower level, that the rest of their body's sunk down to. So I hope that helps, Shruti. Andrea says, hi, Raf. I've been dying to ask a couple of questions in our Saturday online sessions, but hesitated as they weren't really relevant to the day's topic. So thank you for creating this space for questions to be answered in your video each Friday. What a fantastic idea and thing you are doing for us all. My pleasure, Andrea. I get a lot of fun out of it too. I have question one. I have a client who has degenerative arthritis in his right knee, bone on bone, and torn meniscus in both knees. Is there a particular exercise or exercises I could be doing for him, or just general quad, etc. strengthening? Andrea, yes, the best exercise so number one, torn meniscus are extremely common in people over 30, and they get more and more common as you get older and older. And so by the time you're in your 40s, 50s, 60s, the majority of people have some kind of meniscal damage, and it doesn't seem to be a major problem in terms of function or pain. Arthritis in the knees, degenerative arthritis, which is called osteoarthritis, And osteo means bone, and arthra means joint, and itis means inflammation. So osteoarthritis is just inflammation of the joint, and it's an inflammation of actually the cartilage, even though it's called osteoarthritis. And the cartilage degenerates. And it's thought to be partly genetic, partly it's related to lifestyle factors. So people who are obese tend to have more arthritis, and that's not because of the weight, it's because of the inflammatory chemicals that are released by body fat. And then also finally, people who don't exercise tend to have more arthritis than people who do exercise. In arthritis, often people say bone on bone. When I hear that, I always cringe because I think that some, well-meaning health professional at some point has said that to your client, and or they've read it on Google or whatever, and it's just a horrible image to have in your mind about what's going on in your knee, and it's probably factually incorrect. And even if it is factually correct, it doesn't. It's just not a good visual. So I would never use those words with your client again. And here's what I would do. So exercise has been shown to be both safe and beneficial for people with arthritis. The thing that is most important for the health of the cartilage in the knees is movement through full range. So that is, fully flexing and extending the knee and rotating the knee, because the knee rotates a little bit as well. So anything that moves the knee through full range is great. Deep squats, deep lunges, knee lying on your back and doing leg slides in and out, bicycle kicks, anything that bends the knee through full range is great. Because that nourishes the cartilage. Now, loading is also fantastic. So I love your idea of quadriceps strengthening, but don't forget the hamstrings, the glutes, the hip flexors and the adductors and the calves, many of which cross the knee as well. So some of the hip flexors cross the knee, the glutes cross the knee, some of the adductors cross the knee, and the calves cross the knee as well. So it's basically strengthen the whole leg. And if you're doing full depth squats or lunges, that's what you'll be doing. And then finally, heavy strength training and impact activities, like walking and running, have not been shown to be unsafe for people with arthritis. So there is no reason to avoid those activities. They're perfectly safe. If your client is deconditioned and fearful, definitely start them on the easy end of the spectrum and gradually progress them. And if they have pain with a certain exercise, well, do a different, if they don't like running, don't run, go for a swim instead. But it's not something that you need to inherently avoid, like impact or loading. And so I would definitely, number one, move them through full range as often as possible, preferably daily. And number two, load it and strengthen it. And number three, try and just get them engaged back with their everyday activities, walking, running, cycling, doing the shopping, all of those things, anything they can do that is where the pain is tolerable. If the pain is elevated for more than a couple of hours after the session, so if you get some pain during the session, that's not a big deal. Don't worry about it. But if the pain stays elevated for more than a couple of hours after the session, that's a sign that you pushed it a bit too hard and you should back it off again next time. But don't panic, just go a little bit easier next time. Hope that helps. Lisa asks, hi Raf, wondering if possible to address in the next AMA sacroiliac joint sprain and associated lumbar facet dysfunction, and how to work with a client who has this or early stages or late stages of healing and how long it typically takes. Very specific, because this is what I had been told by a physio I had on the left side back in October 2019. Went away completely with Pilates after 2 months, and now I occasionally still experience that same painful twinge on the left if I do hip flexor leg lifts or bend down with straight legs too quickly, moving to the right with my hands. I'd love to know more about this topic so I can help my future clients heal better. Is leg lift seated maybe the exercise with people above should avoid? or reduce range of motion? Is there an exercise that's better suited to assist with the healing and avoiding that pain from occurring there again? Any other info on the topic would be greatly appreciated, as it's tricky to find the right info online, and I would love to learn how to work with that specific injury. Any good articles you're aware of that you can share? Thanks in advance. Really appreciate the AMAs. Well, thank you, Lisa. So, Lisa, I had a dig on through Google Scholar for this, and now what I've found is really an absence of evidence. So I can't really draw any firm conclusions, but multiple searches for terms around sacroiliac joint sprain returned nothing. So I believe that this is my suspicion is that this is a spurious diagnosis, like it's a kind of a made-up condition. So I'm not saying that your pain is made up. I'm not saying that your symptoms are made up. I'm saying that the diagnosis you've been given is quite possibly not a established medical diagnosis. So a sprain is when you strain, stretch or slightly tear a ligament, and ligaments join bone to bone. And so your sacroiliac joint is the joint between your sacrum and your ilium. The ilium is the half of your pelvis, and the sacrum is the wedge of bone in between the two iliac bones, and the sacroiliac joint is a joint between those two. Now, the sacroiliac joint is what is defined as an extremely stable joint. Let's see if I can come up with a picture of it. Here's one. All right, so on the right of your screen here, you see here's a sacroiliac. There's the sacrum here. There's the ilium on the right, and you can see all these grey things. They're the ligaments. Like this joint is wound around with ligaments literally from top to bottom. They're very, very thick, strong ligaments. So this is a highly stable joint. Here's another one looking at the ligaments on the front. You can see it's a very, very stable joint. It only has literally there are a few radiostereometric studies I found where they implant radio-opaque markers into people, like basically stick lead pins into their bones and then have them move under a fluoroscopic X-ray. And they find that the sacroiliac joint moves usually less than half of 1 degree. So this is when someone stands on their one leg and lifts up their knee like that. The sacroiliac joint typically moves less than half a degree. So it's a very, very stable joint. So it seems to me somewhat implausible that would be sprained, the ligament damaged on it, because it's just such a strong joint. And to apply enough force to that to sprain it, you would just think that you'd probably break an arm or a leg or a rib or something. You'd have to get so much leverage onto it to move it, to harm it, that it just it's not that plausible to me. And combined with the fact that I literally couldn't find anything on Google Scholar, not one study relating to sacroiliac joint sprain. However, but what I did find was a few studies on methods of diagnosis of sacroiliac joint related pain, and basically what they found was, let me have a look and see if I can dig out this one that I am thinking of. SIJ. Yeah, this is the one. So this is a systematic review in 2 parts of clinical tests of a sacroiliac joint from the year 2000. And basically what they did is they looked at a whole bunch of tests of the sacroiliac joint that, physiotherapists, osteopaths, chiropractors, etc., do to try and figure out, and diagnose sacroiliac joint pain, what's causing it. And what they found was the conclusion of this methodological review is that there is no evidence to support the inclusion of mobility and pain provocation tests for the SIJ, or sacroiliac joint, in clinical practice. Three major problems have been identified in validating SIJ dysfunction tests. First, poor reliability of SIJ dysfunction tests exists, which what that means is basically different physiotherapists, if you get 10 physiotherapists to all perform the same test on the same person, you'll get widely varying results. Some of them will say, yes, it's definitely this, and others say, no, it's definitely not that. And so the same test on the same person with different practitioners give different results. So that says it's not reliable. Finally, there is a need for the proper use of a gold standard in assessing the validity of SIJ tests. So in other words, even if we had a test where multiple practitioners did the same test and agreed that it's the same result, we don't know if that actually measures if that's actually measuring anything of value inside the SI joint. All that says is, okay, 10 physiotherapists agreed that this test causes pain or this test shows mobility of the sacroiliac joint. Does that indicate there's a problem? Well, we don't have a gold standard test. So normally, like when we're evaluating a test, we might evaluate it against a gold standard of MRI or exploratory surgery or biopsy or something like that. So, okay, then we compare it, does this test give the same result as an MRI or a CT scan? Well, it turns out that MRIs and CTs are also very unreliable and not able to detect these things very reliably. So we don't even have a standard against which to measure these tests, and what's more, different practitioners tend to get different results with them. So I would take that diagnosis with a grain of salt. But if it is a sprain is a minor strain or minor tear, means the same thing, to a ligament. Like if you sprained your ankle, that's a slight strain to the ligaments on the outside of your ankle usually. And we know that the healing time for a ligament is roughly 12 months. And so you said you did this in October 2019. We're now in July 2020. So you said it went away almost completely in a couple of months, but you occasionally get a twinge. Well, if that was a sprain, you had a minor tear in some part of that ligamentous system, well, that sounds about normal to me. That sounds about right. Like if you sprain your ankle, you'd expect it to be super painful for a little bit, but after a couple of months, it probably wouldn't hurt. But maybe if you went running and played basketball, every now and then you get a twinge for the first year or so because it's still healing, right? So if it was a sprain, I think you're doing the right thing. And what I would do under that situation would be continue to gradually increase the load on it. So I certainly wouldn't be avoiding movements. I would be working to the edge of pain and maybe a little bit into pain. Because to promote healing, you want to stress the tissues. You need to apply load, which stimulates the collagen fibers to lay down. So when you heal something, when you heal a ligament, you have a ligament here and it's got some, a bone at each end, and then it's got some kind of tear in it, okay, a little minor tear there. Well, what happens is you lay down, when you heal, you lay down new collagen fibers and you just kind of lay them down every which way in there, just kind of fill in the gaps. And what happens over time is as you load that ligament, okay, as you load it and pull on it, that load itself stimulates those fibers to realign. Okay, so they realign along the lines of tension that is applied to the ligament. Okay, and also it stimulates them to grow thicker. So loading is an integral part of the healing process. Like if you don't load it, it's not going to heal properly. And the best time to load it is in what's called the remodeling phase, which sounds like you're in it now if that was a sprain. So because if you leave it to sit for too long without loading it, it kind of sets, right, with all the fibers going in a disorganized fashion. So you're best to load it within pain tolerance if it is a sprain. I suspect it's probably not a sprain though, because I don't think that's a real diagnosis. And so the other alternative would be that you've got just essentially you're sensitized to that position. Okay, in which case the exercise recommendation is the same, which is gradually progress load within pain tolerance. Like don't avoid pain. work up to pain, push into pain a little, but don't go overboard so you can't walk for 3 days. Just, push into it a little bit, edge up into it, and then edge up a little further, but push it. You should find that your pain tolerance will increase. Your pain threshold will increase. It will be less painful to do the same things. But that'll be a gradual thing over time. If it is a sprain, bear in mind that the healing time is measured in months or up to a year and a half. And if it's not a sprain and it's just a pain sensitization thing, the time frame is variable, but think in terms of months or a year or two. Don't think in terms of 3 weeks of strengthening and we'll fix it. So that's my advice. There's nothing I would avoid. I would just be guided by symptoms, but not avoid the symptoms. Just the symptoms should be, you think about pushing the envelope gently, and the envelope should expand. So you should think about eventually you want to have nothing off limits. Everything's good. Hope that helps. We have one final question, which is from Mel. And Mel says, "Hi Raf, thanks for the Q&A session. Please can you suggest what I can study next? I have a diploma in comprehensive studio Pilates and Cert 4 mat Pilates. I've been teaching Pilates for a couple of years, previously in corporate media relations. I'm not young, 48. Well, hey Mel, I'm 49. But would like to learn more about movement and exercise. I've looked at uni courses, but very expensive, and based on some of the comments you've made in the anatomy courses, I'm not sure the material is what I'm looking for. Maybe a PT qualification might be a nice thing to add. Also, what is the best course for pre- and postnatal Pilates and for older Pilates clients? Would welcome your thoughts. Thanks, Mel." Well, Mel, I'm going to do a bit of a shameless plug here because we are developing a course. We haven't got the name for it yet. So the current working title is it's Clinical Movement Science for Movement Professionals. And, it's not a super sexy name, but we'll get there. And the course the reason that we're developing this course is I think there's a real gap. Now I've been to university. I've got a Bachelor in Exercise and Sports Science. I've got a Master's of Clinical Exercise Physiology. I know a truckload of physiotherapists and osteopaths, and I have done several Pilates qualifications. I know a lot of Pilates instructors, a lot of Pilates instructor trainers, and I see a real, where I see a massive gap in the whole ongoing education scenario is ongoing education for Pilates, and for everyone, for exercise physiologists and physios and everyone, is very, very bitsy. There are Pilates instructors, I think by and large, are voracious self-educators. We constantly attend courses, read books, watch videos, etc. But the thing is, all of these things are premised around a point in time and a point in knowledge. And so you might do something like a 2-hour online webinar or a weekend workshop in some specific thing, how to activate the psoas or how to increase balance for older adults or, prenatal Pilates or whatever it might be. But so people end up over the years with dozens or hundreds of these little tiny courselets that they've done, or little booklets that they've read, or little webinars that they've participated in or whatever. And each one is just one tiny little bit of information, but there's no way to join the dots between them. There's no kind of system or process or framework that holds it all together. And moreover, quite a few of them are often contradictory. So something you learn in one training contradicts something you learned in a different training, and you're left scratching your head and going, well, there are so many grey areas on the map in my brain. I can't see how these pieces fit together. And how do I choose which bit of information to trust, and how do I know what to do with clients when they show up and go, I've got an ache or a pain, or I'm pregnant, or I'm older, or whatever. And so the course that we are putting together, Clinical Movement Science for Movement Professionals, clunky name, is designed. It's not a weekend course. It's actually we haven't set it in stone yet, but it's going to be roughly 6 to 8 months of probably 2 lectures a week, 2 90-minute lectures a week, plus an Ask Me Anything. And it is for people, and it is going to go through. Well, let me give you a little quick rundown of it. It's going to basically go through each body part. So we're going to go through the shoulder, the spine, the neck. I know the next part of the spine, but we're going to do it separately. The hip, the knee, the ankle. Okay, we're going to go through each of these. We're going to go through, for each of them, we're going to go through the anatomy, physiology, biomechanics. I'm talking in depth, like you will know every muscle, you will know every tendon. The pathophysiology. What can go wrong? Pathophysiology. What can go wrong? What's a bursitis of the hip look like? What's a subacromial tendinopathy? What's a chondromalacia of the patella? So you will learn about all of those things in each body part by body part. Movements and exercises. So, how do we, address the anatomy that we've and identified the biomechanics and also the pathophysiology? If we've got an acromial bursa, subacromial bursa that we don't want to irritate, what movements should we avoid or do or whatever? So how all of that. And that will include also stretches. So if we wanted to get more range of motion in this direction or that direction, what would we do? So we're going to go through all of that for each body part. And then there is a section on exercise science and programming. So this is basically how to program for strength. So just say you wanted to increase your quad strength. Well, how many reps should you do? How many sets should you do? What load range should you use? How many sessions a week should you train? How close to failure should you go? Should you do pulses or lift through full range? Like all of that stuff. Strength for flexibility, for neuromotor. So in other words, balance, neurobalance. Neuromotor, how to improve balance and coordination and skill. And then we're going to look at pain science. So, what is pain? How to differentiate pain from injury. And, how to address pain. So now you'll know all of the specifics of each of those body parts, and now we'll look at these factors of, okay, if we wanted to strengthen the spine or the neck or the hip or the knee or the ankle, we know which muscles and movements to use, but now it's like how many reps do we do, how many sets do we do, what load do we use? And then it's like we're going to look at this and going to go, okay, and if we've got an ache or a pain there that is maybe related or unrelated to some kind of injury or pathology or something that's going on in that structure, how do we work around with or through that? And so that is the 5-minute version of what that course is going to be all about. The idea is it gives you a complete framework. So, my apologies. There's one last thing we're going to do, which I forgot there, which is special populations. And this isn't the first thing, goes down in here, but that is osteoporosis, that is pre and postnatal, that is scoliosis, that is arthritis, that is cancer, older adults. All of those folk who don't necessarily have an injury per se, but there's some situation or some aspect of their general health or well-being or age or whatever it might be, that means that they may need some kind of modification or special adjustments to their exercise. So we're going to look at all of those in depth, in detail. And so not just like, what do you do for osteoporosis? Like you'll know like what's going on inside someone's bone when they have osteoporosis and how does exercise affect that on a cellular level. And, but it's not going to be a super, cerebral course. It's going to be highly, highly practical. It's going to be like actionable takeaways. Here's what you do in the real world with a client who has this condition. Here's how you measure it. Here's how you test it. Here's what you say to them. Here's what exercises to do. Here's how hard to do them. Here's how many times to do them a week. Here's how to know if it's too much or too little. That's the design of the course. Is it's designed to join the dots in between all of those little tiny bits of information that you've probably got in your brain and make sense of it all and give you a current evidence-based, up-to-date, complete picture as best as science understands it, because there are some parts of this puzzle that science just doesn't fully understand yet. So that's the plan. And I don't know the price point and I don't know exactly how many hours it's going to be, but it's going to be roughly 6 to 8 months, 2 live sessions a week, which will also be recorded if you can't watch them live, and plus a Q&A each week, like a Ask Me Anything like this is, which will be you basically send in your questions and I will answer them, and that'll be in a closed group. It won't be for public. So that is that. So that's what I would recommend you do is, if that sounds good to you, Mel, is hang out for that. We should be announcing it within the next 4 weeks. We've got to have all of that finalised. All the content's written. It's just a matter of like figuring out the scheduling and the naming is the big thing, and the price point and all of that kind of sort of more mundane details. That's my pitch. So thank you so much for sticking around. If you've stuck right around to the end, you're a fellow enthusiast and I salute you. I hope you're well. I hope your family's well. I hope you're enjoying life. I hope you're loving learning, and shoot me your questions. You can ping me on Slack at Raphael_BE, or you can just tag me on social media. I'm on Instagram or on Facebook. And send me your questions. No questions too big or too small. I can't guarantee I know the answers, but I'll look them up if I don't. See ya.